Hey, what's up? Today we're going to be talking about a mental illness diagnosis and why it isn't what we think it is. So we're going to look at sort of like a mental illness diagnosis, and we're going to compare that to a physical injury or illness diagnosis to kind of see where some of the challenges lie and where their challenges are different. First, we're going to talk about emotions. Now, emotions are sort of like the rules in the game of life. For example, one emotion we can talk about, fear. So people who leave a scary movie early, we could assume either A, they didn't like the movie, or B, they had a lower threshold of tolerating fear compared to those around them. This is a hand on the stove moment, where there's a stimulus that we can tolerate for so long before there's a response. In this example, the stimulus comes from pain, and moving our hand away is the response. Well, like pain, a stimulus causing fear can only be tolerated for so long before we move away from it. Sort of like leaving a movie theater early. All right, back to diagnoses though. Where do they come from for a mental illness? Where do I go get my diagnosis from? Well, mental illness is a broad term. It's used to categorize many different ailments that are found in the DSM-5. This is where we go to find different types of psychiatric illnesses. But the problem with referring to the DSM-5 is it's sort of like referring to cancer as like just a cell, I don't know, replication complication. Sure, it's true. There's a cell problem, but where is it? What kind of cancer is it? Is it benign? Is it moving around? There's a lot of questions usually that follow after somebody says, "Hey, you've got cancer." So just like with mental illness, there's usually a lot of follow-up questions afterwards. The DSM-5 is where we go to get a lot of the objective evidence and facts for things around like anxiety, depression, schizophrenia, ADHD, personality disorders, etc. Okay, so we know where to go. We know where to look now. Great. What is the difference though between like a mental illness diagnosis? How does that look compared to like a physical injury or illness in terms of a diagnosis? Let's take a look at that. Almost anything on the DSM-5, it usually comes with a diagnostic criteria of something along the lines of like, well, symptoms must be present for like X amount of days or X amount of weeks or needs to pop up this many times during the day. Why? Well, to see if it's a mental illness or to see if maybe we're just kind of overwhelmed with life at the moment. For example, clinical depression. For clinical depression, we're going to need to have symptoms like persistent sadness. We're going to need to be anxious. We're going to need to have a feeling of like an empty mood or feeling hopelessness, uh, pessimism that won't go away, irritability and frustration that have no valid reasons for being there, restlessness, guilt, worthlessness, feeling helpless in situations when again, we shouldn't. So essentially what we're trying to determine is, are these symptoms persistent day to day, or do we have a valid reason for them to exist? Do I have a valid reason right now to feel helpless or not? So we think to ourselves, okay, so all we need to do then if we're feeling these things, we just go reach out and we start our treatment. All right, we start our treatment. We're on the right track. But quite often the barriers that we see here, it's difficult to seek treatment when we need to sort of define how we're feeling, but quite often we're unsure how we're feeling or why we're feeling. Sure, I'm sad, but is it persistent? Sure, I'm anxious sometimes, but does it get in the way of my day-to-day life? Questions like these need to be answered, and they have very subjective responses, and they'll vary from person to person. This causes, or so the causes for mental illness, they're quite often unseen. So be it a chemical imbalance, the environment, genetics, or whatever, something is getting in the way. Being unseen means much of the diagnostic information, it comes from our subjective experiences. So we often have to become very familiar with our own feelings, sitting in them, labeling them, tracing them back to what triggered them. And I'll let you guys know a little secret here. It's never triggered by the first assumption in our heads, I promise. So we think we have depression. Our next step is then usually becoming a lot more familiar with our feelings. Now, let's compare that with a broken leg. Imagine, if you will, let's say we broke our leg. We were in a car accident, and even though we can't see the break, we're fairly certain it's broken. How? Pain is usually the first indicator. Also the functionality of the leg, I guess. Can we walk on it? Can we run? Can we move it? Is it facing the right way? Now we go to the doctor with our most likely broken leg, but guess what? doctor is blind. Now, he's studied legs, everyone. He's studied legs. He's read the best Braille books we have in this hypothetical. He knows everything about legs. Dr. Legs, they call him. But we'd still have to describe the location of the break, where the pain's radiating from, what type of pain it is. We'd have to walk in and tell him which leg is broken. We would essentially have to help him navigate through his own knowledge in his mind to get the correct course of treatment. Our blind doctor will now have to decide, well, is this a break? Is it a fracture? Maybe it's a sprain? Or are we lying? He doesn't know for sure. He can't see it. So our subjective explanation of our broken leg, basically our opinion about our broken leg, will have a heavy influence on the course of treatment that this doctor will prescribe. Treatments like, will we get a cast? Maybe we'll just go and get our legs taped up. Or perhaps we're told, hey, just go walk on it for a few months, see if it improves. Now, these all have various impacts on our recovery. And hopefully our explanation got the doctor to the correct course of treatment, or else we may end up walking around on a broken leg. Now, let's replace the broken leg with our depression example. Sure, our doctor, they aren't blind. Awesome, great. But they still can't objectively see the issues that we're coming to them with. Just as the blind physician couldn't see our legs, our physicians cannot see into our minds. Now, of course, it's not to say that physicians should be expected to be mind readers. It's more just to kind of express out there that it's a challenging situation we find ourselves in when we're trying to explain why we feel the way we do. The doctors now need to decide, okay, is this a break? Is it depression? Is this full-blown depression? Is this a response to a major shift in our lives, like a close family death, unexpected death of a loved one maybe, or divorce, something like that, kind of like a fracture? Or is this just kind of like a tough time in our lives? Can we bounce back from this without too much intervention? Kind of like a sprain? Or are we just lying? We can start to understand people's disinterest, hostility, even apathy towards seeking mental illness diagnoses or treatment when treatment and diagnoses basically start with having to define and a lot of times having to defend our own emotions. And the biggest secret there I've found is most times we don't even know why we're experiencing them in the first place to be able to explain them. Side note here, just a quick way to approach a mental diagnosis is often done very directly. So clinicians, weirdly, may often just bluntly ask, hey, do you have a reason to be depressed? It sounds very judgmental, but it sort of determines the course of treatment. If yes, you have reasons, then we know there may be more options for treatment, or we would often target those reasons themselves as part of treatment. Sort of like when a major life event happens, such as like a family member passes or other sudden changes in our lives, we're supposed to experience sadness to a degree. If somebody's passed, maybe there's some anxiousness about how our day-to-day routine will look like without that person, some guilt about what we could have said or wished we said or what we could have reconciled, even reflection on our own mortality. Someone just passed. It's a very easy place to get into our heads. On the other hand, though, say we have a stable job, we have no financial worries, a supportive network, we have hobbies, we engage with them, and we have time for them. We still have persistent sadness? Well, there are a reason for those feelings. We can much more accurately get a feel of where this person might be on a depression scale. Let's jump back into our broken leg here for a second. What's the number one complaint when a leg breaks? It's pain. Now, we all have various tolerances for the degree of pain, just like we talked about earlier. We can sit through it, and some people will handle it well, some people will not, and then there's everything obviously in between. I'm not sure mobility is an issue. It's a close second complaint, but pain is what's intolerable, not the mobility. Now, what's the number one complaint with depression? Well, there really isn't one spoken out loud, but for myself, I believe we can say it's extended periods of time in intolerable emotions. So just like pain, there are emotions that can only be tolerated for so long. How long that is dependent on our own resilience to sit in that motion. Shame, for example, becomes an almost expected and baseline emotion. Being in states like shame, anger, sadness, they have similar impacts as keeping our hands on stoves. We hurt ourselves. Emotions like shame can warp our view of ourselves, where we know we can get up and go for a run. We know that helps with depression, but we just can't. We defeat ourselves before we even try. With no way to explain this barrier, we're reliant on our supports to understand and trust our subjective experiences. So when I say, no, I can't do that, I really need my support not to sit there and just go, why? Think about it this way. You've broken your leg, full cast, and you're resting on the couch, as you should be. And then I come along as your supportive friend and I go, hey, let's go for a run. Now, how much of an asshole am I? I go, come on, it's good for your health. It'll strengthen your leg. Now, I'm right. Exercise is good for your leg. It will strengthen your leg. But do I know if your leg is ready for that type of activity? No. Do you? Probably not if you haven't spoken to your doctor. I'm an asshole because I'm putting an expectation on you that you should be okay to come out and run. I'm acting like your broken leg is not an enormous barrier, so I'm implying that the barrier lies somewhere else. Usually, we can conclude I would ask you to go out for a run for two things. First, I think you're fine. I just think you're fine to go for a run. Second, I may just be really unaware of how a broken leg impacts your mobility. Okay, so let's replace broken leg now with depression. I'm your supportive friend. I come up to you and I go, hey, let's go for a run. This is good for your depression. Same issues as the leg. Neither one of us know exactly the severity of the depression. We don't know how much of a barrier it is. Support then is finding out what the barrier is to going for a run. With a broken leg, it's easy. It's a visible cast. It shows the barrier without anyone needing to communicate that. Plus, it's a universal barrier. Everyone in a leg cast should not be asked to go out for a run. With depression, though, the barrier, one, isn't visible, and two, is different from person to person. This is one of the most common problems with a mental illness diagnosis. It's understanding the illness itself. Any mental illness will come with its own unique barriers and challenges. Yes, exercise is usually helpful for every mental health diagnosis. What's in that person's way, though? Why aren't we able to get up and go do it? What are we telling ourselves when someone reaches out to offer us support? Why would we decline it? These are good questions that can help build firm foundations of trust and understanding between ourselves and our supports. As often the person diagnosed with a mental illness, they're not sure themselves what's in the way. When understanding barriers isn't the focus, we usually see a well-intentioned support person often become just the cause of strife itself. It's how we see supportive relationships break down, essentially. So it's because the person who needs the support, again, they aren't getting it and they aren't sure what it should be. They need help and support finding out what that is. And the support person is usually trying their best, but often they're leaving disappointed with their efforts or as if they're not good at supporting us. And people have a limit to how many times they can do that, kind of leaving the room feeling as though they failed. And I'll be honest, this is usually how we end up with supports accusing us that, you're not trying hard enough in some form or another. Small side note here, if you've ever heard this sentiment before, try harder, or if you've ever said it, you're not trying hard enough, something like that. The problem is you're out of tricks. If you're the person supporting, you're out of tricks, you're out of interventions, you're out of whatever word you want to use. You don't know how else to handle this. And that's usually at the point where people start blaming the sick person. It's very common, happens quite frequently. It's a natural end to something that can be very frustrating. It's frustrating for the person who's going through the mental illness as well. The important part is staying together. The important part is remaining a support. The important part is highlighting stuff like that, coming back to it and reflecting on what went wrong versus trying to blame somebody for their illness. So what did we talk about? We talked about how a diagnosis for mental illness usually plays out. And we talked about a few different factors that are fairly important during the process of it. And we compared it to a physical diagnosis of a broken leg to just sort of get an outside view on how these two different diagnoses can play out. So first up, we went over emotions and their guardrails. Just listen to them. If we're feeling sad or anxious, we need to try and find the source of where that feeling is stemming from. Maybe there's something we can do about it. We talked a little bit about how mental illness itself is not a very good name for everything we're dealing with. It's sort of like calling cancer just like a cell replication complication. It doesn't help us much. We also talked about how objective injuries like the broken leg It's much easier to assess. It's much easier to treat. It's much easier to live with because they're objective. They're visible. Without saying anything, we can communicate a lot of the barriers that we have, like just having a cast on. We spoke a little bit about how mental illness will require us to become a lot more familiar with our own thoughts and feelings. So it's one of the few illnesses or diagnoses where you actually end up having to build a skill essentially to get through it. We also found out that asking somebody to go for a run when they're depressed can be just as much of a dick move as when someone has a broken leg. Don't force your supports on people is essentially what that is. When somebody says no, believe them. If you think that they're not living up to their own expectations or their own abilities, that's what you talk to them about. Not just saying, well, you're being lazy. Talk to them about why you believe they're being lazy. Find out what barriers in their way. It's usually bigger than we think. And the last thing, talk. Discuss. Help someone by helping them understand their own thoughts and feelings. Give them a safe place to talk openly, honestly, and without fear. And I mean that very literally. Think to yourself right now, how many people in your life can you list off that you'd speak openly, honestly, and without fear of judgment about something like, I'm worried I have depression? My guess is not very many. So be that person for someone else. I promise it's a gift.